Welcome back to Emergency Medicine Lecture Series. As we are discussing about the symptoms, in today's lecture, I'm going to discuss an emergency approach to a patient who is in respiratory distress. I'm Dr S Prakash Babu, MD Emergency Medicine, Associate Professor, Department of Emergency Medicine. First, let us look at some of the definitions that are used for a patient who is in respiratory distress. First of all, and most prominently used is dyspnea, which is a feeling of difficult or labored or uncomfortable breathing, and it is often described as shortness of breath or breathlessness or not getting enough air by patient. Tachypnea, is rapid breathing. The rate of breathing is increased. And then there is orthopnea, which is dyspnea in recumbent position. In normal position, the patient will be normal. Most commonly is due to left ventricular failure, diaphragmatic paralysis, and COPD. Then paroxysmal nocturnal dyspnea is an orthopnea that awakens the patient from sleep, prompting an upright posture in order to resolve breathlessness. This orthopnea and paroxysmal nocturnal dyspnea are characteristic of pathology in the heart, and they differentiate respiratory pathology from cardiac pathology of as causes for breathlessness. The next is platypnea, which is opposite of orthopnea. Patient will have dyspnea in upright position. The causes are loss of abdominal wall muscular tone, right to left intracardiac shunting. Trypopnea is a dyspnea associated with lying on one particular side of the body. If one lung is affected more than the other lung, as in pleural effusion or empyema, you can see trypopnea when patient lies to the same side. Hyperapnea is essentially hyperventilation and is defined by minute ventilation, which is in excess of the metabolic demand. And let us come to our topic of discussion today, the respiratory distress. Is a term used by the physician combining patient's subjective sensation of dyspnea with signs that indicate that the patient is having a difficulty in breathing actually. That is respiratory distress. Ventilatory or respiratory failure occurs when the lungs and the ventilatory muscles cannot move enough air in and out of the alveoli to adequately oxygenate the blood and eliminate carbon dioxide. Coming to the pathophysiology, multiple factors interact in producing the sensation of respiratory distress. This can be either actual lack of oxygen or it can be the response to the lack of oxygen. And different patients will respond differently. If you look at the exact pathophysiology, there is a central chemoreceptor, peripheral chemoreceptors, which sense the level of oxygenation and the carbon dioxide. And there are groups of cells that are surrounded by fenestrated sinusoidal capillaries. And there is the central nervous system interplay, which shows exactly the effect. The central chemoreceptors are located in the cranial nerve nuclei of 9, 10, and 11. They sense the CSF, carbon dioxide, by glial cells and capillaries. Chemoreceptors, they sense either oxygen or the H plus ion concentration or the carbon dioxide concentration. And then there are peripheral chemoreceptors located in the aortic bodies of the ascending aorta. Vagus nerve supplies these aortic bodies. And there are carotid sinus nerve, which supplies the carotid sinus, which is another peripheral chemoreceptor, which is located at the bifurcation of the carotid artery into the common internal carotid artery and the external carotid artery. It is supplied by the glossopharyngeal nerve. Again, they sense the oxygen and the carbon dioxide concentrations. These signals through the ascending pathways reach the dorsal and the ventral respiratory groups. From dorsal and ventral respiratory groups, the sensation is carried to the pneumotaxic center, the pons, and from pneumotaxic center through the hypothalamus, which controls the emotion and the temperature, it reaches the cortex. Cortex is the higher control, voluntary control where the pyramidal tracts can happen. And then the cortex sends back the signals through the pneumotaxic center to the dorsal and ventral respiratory groups. They send signals to the spinal cord, and the respiratory muscles are activated, and lung receptors are activated. In the lungs, there are stretch receptors, which sense the stretch, and that is conveyed to the degree of stretch is conveyed to the dorsal and ventral respiratory groups, which again controls the extent of respiration. Common causes of dyspnea in the ED. Some most common causes and some immediately life-threatening causes. Most common causes include obstructive airway disease like asthma, chronic obstructive pulmonary disease, decompensated heart failure or acute cardiogenic pulmonary edema, ischemic heart disease like an unstable angina, myocardial infarction, pneumonia, and psychogenic. The causes which immediately threaten the life, and you need to focus on these, diagnose as early as possible, and treat the condition within the ED include mainly the upper airway obstruction because of foreign body, angioedema, and hemorrhage, tension pneumothorax, pulmonary embolism, neuromuscular weakness like myasthenia gravis, Guillain-Barré syndrome, and botulism. And don't forget fat embolism. Fat embolism is very common in patients who have long bone fracture or those who got operated for long bone fractures. Keep that in mind. Coming to the clinical features of respiratory distress, the physical signs that are associated with dyspnea include tachypnea and tachycardia, the very common. There will be use of axillary respiratory muscles like the sternocleidomastoid, the sternoclavicular muscles, and the intercostal muscles. There will be nasal flaring, inability to speak normally as a consequence of air hunger, agitation or lethargy as a consequence of hypoxemia, depressed consciousness due to hypercapnia. There will be paradoxical abdominal wall movement once it reaches extreme stages. You need to be very, very careful when you are evaluating a patient with respiratory distress. You need to rule out all the physical causes, first the life-threatening causes and then other physical causes before you come to a conclusion the patient's respiratory distress is hypogenic. Most important historical features that you need to ask are as follows. The aim of taking history in a patient with respiratory distress is to ascertain whether there are any ongoing cardiovascular, pulmonary, musculoskeletal, psychiatric illnesses. You need to collect history regarding onset, duration, and occurrence of breathlessness with rest or exertion. Ascertain orthopnea and PND. Ask for associated features, especially cough, sore throat, pleuritic pain, which indicate a pulmonary origin of breathlessness. Edema of the feet with facial puffiness indicates a cardiovascular origin of for breathlessness. Fever indicates infection. Indigestion and dysphagia indicates a gastrointestinal cause, which can mimic breathlessness. You need to ask history about smoking and other forms of tobacco use, which are most common cause leading to development of both heart failure and COPD. Comorbid illnesses like diabetes, hypertension, asthma, any cardiac, liver, and renal pathologies need to be focused on. Focus especially on the current medication, like in the sample history. Take past medical and surgical histories. Any past respiratory illnesses, if the patient has been intubated earlier for anything, or patient is on NIV, home oxygen therapy, these points need to be very meticulously documented. Factors provoking aspiration, like alcoholism, has to be documented. And most importantly, the last meal, timing, composition, and amount, and any chances of aspiration of the gastric contents has to be meticulously recorded. Physical examination, rapidly assess ABCs and institute appropriate measures to stabilize the patient. Assess the patient's signs of respiratory failure like altered consciousness, inability to speak, diaphoresis, inspiratory retractions of the chest wall, nasal flaring, and paradoxical respirations, which indicate the patient is going into a ventilatory failure. Look for hypoxemia using a pulse oximetry. Look for distension of the neck veins, thyromegaly, and tracheal deviation. Palpate for crepitus, which indicates subcutaneous emphysema in a patient who had a trauma, can be due to pneumothorax. Look for stridor. Carefully auscultate the lungs, checking the breath sounds, looking for any axillary sounds like crepitation, which can be localized bilateral or wheezing. Percussion for dull or hyperrhythmic note will tell you whether the patient is having a fluid or a gas in the pleural space. Auscultation of the heart may reveal presence of dysrhythmias, cardiac murmurs, or aberrant heart gallops. S3 gallop, if present, is due to cardiac overfilling, which is seen in left ventricular systolic dysfunction and in congestive heart failure. S4 gallop says left ventricular dysmobility and dysfunction. Loud P2 indicates pulmonary hypertension, and muffled heart sounds indicate cardiac tamponade. Never ever miss examination of other systems which can give clues to the diagnosis, especially the abdomen. Look for hepatomegaly. If there is tender hepatomegaly, that indicates the patient is having a heart failure. The first and foremost sign is there will be hepatomegaly, and carefully look for hepatojugular reflux. A positive hepatojugular reflux again indicates early stages of cardiac failure. Look for abdominal distension, noting for 5Fs, especially ascites, which can lead to abdominal distension and splinting of the diaphragm. Diaphragm cannot expand, so the lung volume is reduced. That can lead to breathlessness. Look for the lower extremity edema, pitting or non-pitting edema. The edema is pitting, it is due to a failure of one of the organs like heart, liver, and the kidney. If it is non-pitting edema, it can be due to either DVT or filariasis. Especially note whether the edema is unilateral or bilateral. Unilateral edema is again DVT, bilateral edema is due to systemic cause. Look for distal clubbing again, which indicates your chronic diseases. Cyanosis, central cyanosis or peripheral cyanosis has to be noted. Central cyanosis indicates problem with the lungs and the heart, and peripheral cyanosis indicates problem with the vascular beds. What are the investigations you are going to do in the emergency room after you have examined and come to your diagnosis? The first and foremost investigation which should be an adjunct to the primary survey is the pulse oximetry. Rapid assessment of arterial oxygen saturation is required. You can go for a arterial blood gas analysis on bedside. Point of care testing detects impaired blood gas exchange, calculates PaO2 gradient. If you want to know much more about arterial blood gas analysis and interpreting the report, you can go my video on ED arterial blood gas. Bedside spirometry. The only thing that can be checked on the bedside is peak flow rate using PEFR, which detects obstructive airway disease. It might be difficult to perform in most ED patients because they will be terminally ill. Negative inspiratory force during spirometry indicates the strength of the diaphragm and the inspiratory muscles. Co-oximetry can be used to detect methylhemoglobin and carbon monoxide poisoning, which are frequent causes for breathlessness. Bedside lung ultrasound. It can differentiate acute decompensated heart failure from non-cardiac cause of acute dyspnea. It can also identify pleural effusion, pneumothorax, cardiac tamponade, cardiac functional abnormalities, and pulmonary consolidation, intravascular volume status. The differentiation between heart and lung disease using ultrasonography, I will deal with another lecture. CBC can be done, which shows possible infection if there is leukocytosis. Hemoglobin content will indicate anemia, which can be a cause for breathlessness and cardiac failure. Elevated BNP due to ventricular overload, including heart failure and strain, myocardial ischemia, pulmonary embolism, and sepsis. Chronic obstructive pulmonary disease with carpulmonale can be a cause for elevated BNP. You can go for D-dimer if you are strongly suspecting a pulmonary embolism. ECG is one of the foremost investigations that should be obtained within 10 minutes of patient arrival to the ED. It detects myocardial ischemia, infarction, any rhythm abnormalities in the heart, and also useful for assessing certain electrolyte abnormalities like calcium, magnesium, and potassium. Imaging studies. The initial modality is chest X-ray, but keep in mind pneumothorax, especially the tension pneumothorax and massive pneumothorax, should be a clinical diagnosis supported by your bedside ultrasound. You should never do a chest X-ray in a patient who has a suspected tension pneumothorax or a massive pneumothorax. A 2D echocardiogram, which is useful for evaluating the cardiac function and also the valvular function. VQ scan if pulmonary embolism is suspected. Spiral chest of the CT, which is an alternative to VQ scanning if there is involvement of the kidneys. Cardiac catheterization can determine pulmonary hypertension, intracardiac shunting, and coronary artery disease. You can subject the patient to exercise pulmonary function testing if the patient is stable enough. If it is abnormal, fixed cardiac output state, or exercise-induced asthma. If the exercise pulmonary function testing is normal, it is due to decongestioning, psychogenic dyspnea, and a hypermetabolic state. Sputum can be collected for gram strain and AFB, which can give you if there is an infection. Bronchoalveolar lavage, again for finding any malignancy or for subjecting it to gram strain, AFB, and culture. Blood and sputum culture can also be done. So if you follow a diagnostic algorithm, specifically focusing on a specific life-threatening conditions, you will be able to manage a patient with respiratory distress very well. Patient presented with respiratory distress, which is indicated either by respiratory rate of greater than 24 or less than 8, or tripoding or uses of accessory muscle, or retraction, shoulder mental status, abnormal chest movement. No, you go for pulse oximetry, supplement oxygen, history and physical examination, and directed evaluation based on the clinical diagnosis. If patient has respiratory distress, you need to start with supplemental oxygen, check pulse oximetry, get an IV access as early as possible, put the patient on multi-channel cardiac monitor, and continuous waveform capnography should be monitored. The patient is unable to maintain his own airway as there is evidence of respiratory failure. You need to assist ventilation either by a non-invasive ventilation or by endotracheal intubation. Assess breath sounds. The chest is unequal or the breath sounds are unequal on both sides, so absent on one side, present on other side, or there is history of trauma to the chest. Patient is in hypotension, shock, tracheal deviation, JVD, ultrasound evidence of pneumothorax. If yes, immediate chest decompression using needle decompression has to be done. If these features are not there, bedside ultrasound with cardiac collapse and pneumothorax can be noted. Endotracheal intubation can be performed if the patient is in respiratory failure, or cricothyrotomy and mechanical ventilation can be instituted. Get a chest X-ray done. The chest X-ray assess for breath sounds, obtain history and physical examination. Once these investigations are at hand, BNP is positive. There is interstitial pattern on the chest X-ray. This is a case of pulmonary edema. ECG will support the diagnosis in case of pulmonary edema. If it is a cardiogenic pulmonary edema, the treatments for cardiogenic pulmonary edema includes diuretics, nitrates, ACE inhibitors, morphine. Consider CPAP or BiPAP as mechanical ventilator mode. On examination, there are VGS, the lung is clear, chest X-ray is normal. Consider anaphylaxis, bronchospasm, sharp fin EtCO2 waveform can be seen in these cases. The treatment is bronchodilators, epinephrine, steroids, and antihistamines. There are diminished breath sounds, diffuse rhonchi, infiltrates on chest X-ray. It can be either pneumonia or pleural effusion. Antibiotics and blood culture are indicated. Chest is clear with or without chest pain. Consider pulmonary embolism or angina equivalent neuromuscular disorders or central neurogenic cause. Then do a D-dimer, triple contrast CT can be done. ECG and troponin will be supportive. ECG, if it is showing S1Q3T3 pattern, which is seen in only 28% of patients, right-sided heart stent, sinus tachycardia, NSS-TWC, consider PE. The troponin is elevated, it's ischemic cardiac disease. Evaluation and treatment in conjunction with a cardiologist is indicated. Obtain an ABG. ABG is abnormal. Check for a arterial alveolar oxygen content gradient. Anticoagulate, VQ scan, pulmonary angiogram, and spiral CT are the treatment of choice. So we have seen the algorithm on how to manage step by step. Now going into treatment paper, acute dyspnea is more often a life-threatening cause. All efforts must be taken to identify and treat the cause. All patients should be placed on supplemental oxygen, pulse oximetry, and a cardiac monitor. Target an arterial oxygen partial pressure of greater than 60 millimeters of mercury or oxygen saturation of greater than 90%. Never ever target oxygen saturation of 100%. Mechanical ventilation in the form of NIV or invasive ventilation can help achieve these targets. So this is another algorithm that you can follow. Complete initial evaluation with vital signs and saturation. Start with supplemental oxygen. Cardiac monitor, IV access. Differential diagnosis is based on history, physical examination, and the vital signs. There is a history of trauma. Immediately you go for FAST or EFAST. Tension pneumothorax, immediate chest decompression by needle or tube thoracostomy. There is pulmonary contusion or multiple rib fractures. The most important thing is pain management and oxygen saturation maintenance. Inhalation injury, early endotracheal intubation is indicated. The patient is having anaphylaxis, secure airway when needed, endotracheal intubation, cricothyrotomy, epinephrine IV or subcutaneous, steroids IV, diphenhydramine IV, inhaled beta agonist, consider inhaled racemic epinephrine, Heliox, H1H2 blockers IV. There is pneumonia or infectious cause, as I told earlier, send blood and sputum cultures, start antibiotics. There is cardiac cause, patient presented with chest pain, obtain ECG. There is suspicion of pulmonary embolism, D-dimer, asthma, COPD exacerbation, inhaled beta agonist, steroids IV, consider other adrenergic agents. If all these medical measures fail, then you can go for mechanical ventilation using either CPAP or BiPAP initially if the patient is conscious. If the patient is unconscious or there is a reduced GCS, go for endotracheal intubation. Thank you. Don't follow your dreams, chase them. You will reach your targets. Thank you once again. Don't forget to share and subscribe the videos.